Talks Glaucoma session. I request our chairperson, Dr. Gursatinder, to please sit on the dais. Dr. Anuradha, Dr. Suresh Kumar, I think they are not here. So I request our panelist, Dr. Neetu Negi, to also join the dais. Dr. Neetu Negi, please join the dais. Dr. Tesh is not here. Dr. Munish Dhawan, please join the dais. So I welcome all for a wonderful session of Glaucoma POS faculty talks. I invite Dr. Talveer Sidhu, our first speaker, to speak on diagnosis and management of glaucoma suspects. Handing over to Dr. Talveer.
Thank you. So I'm going to talk about diagnosis and management of glaucoma suspects. So when you say why is a person glaucoma suspect, either the person has a high intraocular pressure and normal optic disc and visual fields, that means the person is ocular hypertensive, or either the disc is suspicious or the visual fields are suspicious. And this excludes all the angle closures, pseudoexfoliation, pigment dispersions and traumatic angle recessions. Why are the discs labeled suspicious? So either there can be enlarged cup to disc ratio. So here you can see this is a very large disc with a cup to disc ratio of almost 0.8, but you can see that the visual fields and OCT are normal, RNFL is normal. Atypical neuroretinal rim. Here again you can see that the neuroretinal rim is sloping, there is excavation, there is thinning of the neuroretinal rim in the superior and inferior parts. However, the visual fields are normal. Asymmetry between the eyes is another thing when you mark the optic disc suspicious. So you can clearly see that there is a size difference as well as there is a cup disc ratio difference in both the eyes. However, the RNFL is normal. It's important to know when a person that you have marked as a glaucoma suspect can progress to glaucoma. If there is localized thinning of the neuroretinal rim, if there is inter-eye asymmetry, if there is high pattern standard deviation, if there is older age, family history of glaucoma, thin pachymetry or higher intraocular pressure. All these risk factors must be noted in every glaucoma suspect so that you can predict when to follow up them. So if you have a person who does not have any risk factors, you can follow them up annually or 2 yearly, and if they have multiple risk factors, obviously 6 monthly follow up can be done. So management of primary open angle glaucoma suspects. If the person is ocular hypertensive, in India, if the IOP is more than 26, you might as well start treating them, because to a normal IOP that is less than 18, thin CCT, older patients, you have to review them 6 monthly, and visual fields have to be done in the first year at least 2 to 3 times. If it's an optic disc suspect, if there is a family history, if there is a CDR asymmetry, NRR thinning, then you can review 6 monthly. If there are no risk factors, you can review them annually. Also beware of glaucoma mimickers. So here I have put in multiple photographs. Here you can see that this is a physiological cupping. This is a typical neuroretinal rim notch with an inferior RNFL defect, which is glaucomatous. However, this is a pituitary adenoma which is presenting with temporal pallor along with rim thinning, which can be easily confused with glaucoma. Optic disc colobomas, optic disc pits are other things. So visual fields that are similar to arcuate scotomas can be retinal vein occlusions, retinal colobomas, NAIONs, myelinated nerve fibers. Also non-glaucomatous visual field defects which can lead to tunnel vision. They can be retinitis pigmentosa, PRP that has been done, CRAOs, or bilateral infarct in the optic areas. So these are very important to note. So here, can anyone tell me whether this person is a glaucoma suspect or a clear glaucoma? Can we visualize anything here which correlates with the abnormal OCT? So there is a RNFL defect that is actually hidden behind the vein. So this is a RNFL defect here, which is clearly correlating with the abnormal OCT. So this is an early glaucoma. Here this is also a tilted disc where you can see that the OCT is marking it abnormal, but you can see that the double hum sign is present, but it is shifted from the normal area. So now coming to primary angle closure suspects. Primary angle closure suspects have iridotrabecular contact in 180 degree. However, when you open up the angle, there is no pass. The IOP is normal and disc changes are okay. However, it's important to know that 22% of these can convert to primary angle closure in 5 years. So keeping this in mind, where do you do a YAG iridotomy in primary angle closure suspect? If the person is one-eyed, if the person has this is a fellow eye of a PACG, if the person needs repeated dilation, there is family history of glaucoma, there is prior history of acute or intermittent angle closure, or if there is progressive narrowing of the angles. So annual review can be done. If there are no risk factors, if there are multiple risk factors, then YAG iridotomy can be done. If there is a visually significant cataract, then a phacoemulsification can be considered. Risk factors are important to be identified in these patients. Family history of glaucoma in first degree relatives, very narrow angle, high global indices, inter-visit IOP fluctuations are very important to be noted in these patients because they could be having relative pupillary blocks in between. Young onset PACS, that's also very important. Laser iridotomy, it's important, it has to be done almost 0.5 millimeter inside the limbus, and please be careful of not trying to do multiple iridotomies in a thick iris. Try to use a coagulative laser before if it is a thick iris, and YAG PI cannot be done in the first go. Also, is an iridotomy sufficient? Sometimes iridotomy is not sufficient. Why? Because after YAG iridotomy also, gonioscopically persistent angle closure has been found in up to 50% of patients. So you must repeat gonioscopy after you have done iridotomy in any patient. If the angle does not open up, think of plateau iris or a very thick iris or a very high lens vault just like this patient. So in these people, laser iridoplasty augmentation might be needed to open up the angle so that the patient might not keep suffering from angle closure despite a patent YAG iridotomy. So follow-up annually is what you have to do for PACS. However, keep in mind if there are multiple family risk factors, family history of glaucoma, otherwise risk factors. So these patients, they need to be followed up annually. You must get a complete family history of glaucoma as well. Thank you.
You very nicely presented all the scenarios. So I think the one gray area is, normal tension glaucoma,
Yes.
because the patient would come to you with a normal tension, maybe early OCT changes or field changes. So what are the different things you would like to rule out in these cases?
Sir, first of all, in India, we know that the steroid use is very rampant and very prevalent. So important thing first to rule out is, has the patient been using any Ayurvedic eye drops or any steroid for a very long term? So these steroid-induced glaucomas, when they stop using steroids, later on they have a 0.9 cupping. However, the IOPs might be 10, 8. So these are all burnt out glaucomas that might come to you, right? Another thing that I usually try to see in normal tension glaucomas is sleep studies, sleep apneas. These things are also very important. Sometimes in people who have coagulopathies, they might have carotid plaques. So in a patient, I just had a patient who has a 0.9 cupping in one eye, 0.6 cupping in the other eye. IOPs are similar. So I'm getting a carotid Doppler done in that person, right? So these are the things that you keep in mind, and you have to rule out those things. Also, glaucoma mimickers, obviously I've already mentioned, those need to be ruled out in these patients.
Yeah, of course, and then there are a lot of other things. I want to rule out any hemorrhage, postpartum hemorrhage, any history of trauma, or any patient having any kind of get this for any kind of a tumors. You have to rule out all those things. And
Glaucoma
plus, of
mimickers,
course,
yes.
diurnals are very important in these cases.
Yes.
In these cases, they have a suspicious disc, and then you have to rule out. And the history is very important in these cases. I think NTG is a diagnosis of excluent rather than a diagnosis itself. And the other thing I just want to ask you is that a lot of glaucoma suspects, they have, like we call red disease, they have maybe little changes in the OCT. We know that the field effects would appear when the 50% or 40 to 50% neurons or RGs are already gone. So if you find something, in the OCT, and you find little notches there or some semblance of, something you find in the disc, so they are glaucoma suspects technically.
Definitely.
How would you go ahead with these cases?
The first thing is, the important thing is to do a dilated fundus examination. See, your dilated fundus examination, especially with a green light red free filter, will let you know that there is a RNFL defect that you can see on the fundus photo, right? Few people who have chorioretinal degeneration in high myopes, you might not be able to see the RNFL defects. Second thing is that when you do a RNFL circle around the disc, please look at it very carefully whether your fundus is rotated downwards, externally rotated. Then the double hump sign, it was there in the tilted disc that I showed, but it was shifted from the normal. That is why it was flagged abnormal. So is it just flagged abnormal, or is it actually abnormal? These are the things that you need to see. The double hump sign is something that sometimes shifts to the nasal or the according to the rotation of the fundus. In a superior oblique palsy, for example, that double hump sign will shift. The OCT will flag it abnormal. So those are red diseases. Green disease is where there is a very small RNFL defect, but the OCT cannot pick it up because it is very small. But we can see it with our eyes, right? So those are the people we have to be really careful about. So clinical examination is the first thing. OCT is to rule out glaucoma rather than ruling in glaucoma. Diagnosis of glaucoma is your clinical examination. OCT is to rule it out, right? Mostly. Thank you.
Thank you, Dr. Talbir, for a nice presentation.
Thank you.
So our next speaker is Dr. Neetu Negi. She will be speaking on managing glaucoma and dry eye disease, a challenge. So I welcome Dr. Neetu Negi for her talk. So both are working at here.
So, very good morning to all of you. Well, we know that the incidence of dry eye is increasing, and at the same time, the incidence of glaucoma is also increasing. So, to manage both the things together is a big challenge for us. So, I shall be discussing this in my topic. So, is there a relationship between glaucoma and dry eye? Well, there has been close to 800 odd articles which have been published to address this question. And most of the studies have found that glaucoma patients have 40 to 70% prevalence of dry eye, as shown in the studies worldwide. So there is a study which has essentially taken data from the German registry and which has close to 20,000 glaucoma patients. And they found that 52.6% patients had concomitant diagnosis of dry eye, and most of the patients were on monotherapy. So they concluded that glaucoma patients with ocular surface disease experience significantly adverse ocular effects than those without, and the presence of dry eyes negatively influences glaucoma patients' quality of life and ultimately compliance. So why glaucoma patients have higher risk of dry eye? As we all know that it is a chronic disease which needs treatment for years together, and most of the patients will need 2 or more than 2 drops within 2 years of starting treatment. And on the top of it, we are using preservative-containing drops, which has its own side effects. So coming to the, whenever we are looking into the ocular surface changes, we are essentially talking about 2 main things. First is the direct impact of the drug, and second is the indirect impact, which is because of the preservative. So coming to the direct impact, most studies have shown that prostaglandin analogs, they cause obstructive meibomian gland disease. Beta blocker, they decrease basal tear turnover rate, reduces corneal sensation, and bring inflammatory changes in the conjunctiva, whereas alpha adrenergic agonists, they cause high incidence of ocular allergy. But it is the indirect effect which is more important because of the preservative, and to be most precisely because of the BAC, which is a very effective preservative because of the high antimicrobial property, but it reduces goblet cell density, affects corneal epithelium by causing loss of microvilli, accelerating desquamation and cell wrinkling, and increases inflammatory marker like MMP. So then we have polyquat, which is also present in some of the glaucoma medications and is known to cause less toxic ocular side effects. So there is a concept of dose-dependent toxicity. So what should be the upper limit of BAC usage? So the study done has shown that if we are using more than 4 drops and more than 2 topical glaucoma medications daily, that is a strong predictor for development of ocular surface disease. And in our routine glaucoma practice, we are usually going beyond this only. So then there's the concept of concentration dependent toxicity. We have a variety of glaucoma drops available with us with a variable amount of back concentration, and we know the higher the back concentration, higher is the chance of ocular surface disease. So whenever we are seeing a patient of glaucoma who has pre-existing dry eye or develops dry eye in long-term glaucoma treatment, then we can opt for a drug which has lower back concentration. So what are the key points to remember when examining ocular surface of glaucoma patient? First is to identify the surface disease as early as possible, then evaluate it with all the diagnostic tests and devices, go for preservative-free medications, look for treatment options beyond artificial tears, and go for alternate glaucoma therapies. So how to approach these patients? First thing is that we have to look for certain risk factors, which are the strong pointers towards the development of dry eye, and we should look for old age, peri-post menopausal women, high screen exposure time, whether the patient is on autoimmune disease or whether he is on any systemic medications. Then we have simple questionnaires which are available on the web. The most commonly used is the OSDI and DEQ. So what we can do is we can ask our patients to fill the form, and just by looking the severity of the complaints, we can assess the severity of the dry eye. Then simply by doing a clinical evaluation, looking at the lid margin, conjunctiva, tear meniscus, debris, doing fluorescence staining, Schirmer test, tear film breakup time, these all are the simple tools that we can easily do in our routine OPD practice. So here you can see a patient's right eye having a circular ring on the corneal fluorescence staining pattern. So probably this is because of the 80 head imprint, and this is why, because the patient's right eye is on a glaucoma drop since last 8 years. So these are certain subtle signs which you can easily look on slit lamp examination that should not be missed out. So if a normal patient comes to a single agent, minimal possible dose, routine lubrication is not indicated. But if a patient with pre-existing dry eye comes to us, then treatment as per DUE's 2 recommendation can be given, which is an easy treatment protocol available online. It is a step ladder approach. I'm not going into the further details, but yes, to just crisp out, we should go for lubricants, preservative-free lubricants. Then we should try ocular surface modulators like cyclosporin, which has shown to produce wonderful effects in severe dry eyes. Then we have lifitegrast also with us, and we have punctal plugs. And then one thing which I have incorporated in my routine practice is that I ask all my patients to do warm compresses that really helps in meibomian gland dysfunction. So here I had a patient whose both eyes showed ocular surface changes, as you can see on the fluorescence staining pattern, but the left eye had more of the changes. Why? Probably because the right eye is on single drug, single dose. Left eye is on 2 drugs, 3 doses, which means back exposure 3 times. And what I did here was I switched to combination therapy in left eye. So coming to the modifying part of glaucoma treatment, we should go for preservative-free drugs. Then we have newer preservatives like purides, polycoads, Sofzia, which are less toxic and cause less ocular side effects. Then we have combination therapy. We can go for switching the active component if that particular component is causing allergy to the eye. And if the patient presents with severe allergy, then we can go for topical AGM holiday, which means we stop all the topical drops, start oral medications, start steroids, lubricants, and let the conjunctiva heal. So here a patient presented to me, very severe ocular allergy, severe periocular dermatitis. Patient was on brimonidine timolol combination. So what I did was I stopped all the AGM, and then 2 weeks later on the patient presented to me like this. So going for alternate glaucoma therapies, we have SLT can be used in the primary initial therapy in patients having dry eye disease. Then we have minimally invasive glaucoma surgeries, and then we have newer drug delivery systems as sustained drug delivery systems. So to sum up, both dry eye and glaucoma are closely related. We should actively look for dry eye before starting the treatment. We should keep the medications to minimum. Lubricants, preferably preservative-free, will be needed in most of the cases, and modifying the treatment based on the ocular surface health and patient symptoms. Thank you.
Thank you so much, Dr. Neetu. Very wonderful talk. Quick question of discussion. Do you give lubricant in all your cases, like for glaucoma patients? Because some people feel that adding lubricant might hinder with the compliance. So do you prefer giving lubricant in all your cases?
No, just as I said in my slide, if the patient is on single drugs, minimum dose, and if there are no ocular surface changes happening over there, no complaints by the patient, then no lubrication is needed.
And what is your take on preservative-free AGMs? Like some companies say that BAC is required for drug penetration. So what is your personal experience if preservative-free, like a lot of companies have come up with 100% preservative-free novella packing. So do you feel that efficacy is decreased in those cases, or is it similar to the standard?
No. It is very similar to the ones having BAC. So there is no decrease in the efficacy, and they are, drug of choice in our further glaucoma practice, because they are most of the companies are coming with these preservative-free medications, and they definitely do work in patients having ocular allergies.
So you stop all the anti-glaucoma medications if allergy is there, or find the offending agent, because most likely it's a brimonidine or it's a CAI.
Yeah, yes, sir.
As such, prostaglandins and the beta blockers, they hardly lead to allergy.
Yes, sir. Yes, sir.
So I think instead of stopping all the anti-glaucoma medications, you have to take a call on which one is the offending agent.
Yes, sir. That's right. Because the patient was just a glaucoma suspect, the patient who presented to me.
Okay.
So I did stop all the drugs and then go ahead with the investigations. And then after looking, I started with the prostaglandin.
Because the most common offending agent is the alpha adrenergic agonist.
Yes.
Brimonidine is the most common, but there are allergies with the, like brinzolamide, dorzolamide, but
Yes.
they're much less common.
Yes, sir. Yes, sir. Yes, sir.
Dr. Neetu, thank you for a very wonderful presentation.
Thank you.
As sir has very rightly told that while we are stopping, we should not stop all the anti-glaucoma
Yes,
drugs.
sir.
And we should maintain the intraocular pressure with oral drugs also in the meantime.
Yes, sir. So that I told, we can switch to some oral drugs for the time being.
Thank you, sir. Thank you.
Okay.
Thank you so much, Dr. Neetu. Next presenter is Dr. Gursatinder Singh, one who doesn't need an introduction. Sir is teachers of teachers for glaucoma specialty and has been teaching glaucoma since ages. Sir will be speaking on perspectives on progression of glaucoma. Thank you.
Thank you, Dr. Gaurav. So we all know that progression is the one thing which we have to be watchful about in our clinical practice, So this is, a natural history of progression in glaucoma. It's undetectable initially. When RGC loss is there, it becomes asymptomatic when you can pick up maybe with a good disc examination. And then, of course, the functional damage will ensue in the long term when you have visual field changes, OCT changes. And this is a natural, progression. And the idea of the treating a case is like this is a normal progression of the RGCs we keep losing throughout our life. But this is a person who having glaucoma, but he is probably going to have a good vision till his lifetime. But this patient is going downhill. So he is really going to go blind unless you intervene in the timely manner. So these are the various methods of detecting progression: disc changes, perimetry, OCT, and OCTA. Stereo image is a very good or preserving and following up the patient. If you look at this stereo image, you can see that there is disc is normal, but this is 2 years later. You can see there is a superior thinning is developing, and which can be seen very nicely in the stereo photographs. And of course, when you do the optic disc assessment, you know that there is a beta zone atrophy is the one which has been associated with the progression of glaucoma. If beta zone atrophy increases, that indicates progression is there. And of course, if we have a disc hemorrhage, which is called trans hemorrhage, that again is indicative of progression in glaucoma, though you have to rule out the other causes, and it's more common in normal tension glaucoma cases. Similarly, you should be able to find out and delineate the margin of the disc. Should be able to see which is there's an inferior notch here, the inferior thinning here, and you have to document these cases. If you can't have photographs, you should make a line drawing of these discs and follow up with that. And of course, such disc, it may be difficult to delineate the disc margins. And of course, this is a disc hemorrhage. So hemorrhage, you can be seen better if you have a red-free photograph. You can see this hemorrhage. It may look like a vessel here, but it is actually hemorrhage. In perimetry, there are two things. What we look at is VFI and mean deviation. I'll be talking mainly about this VFI. Normally, visual field index is 100%, and mean deviation is negative value. How much less it is the mean deviation? It's a negative connotation is there. If you look at the mean deviation, normally the visual decline is 0.06 decibel every year. If glaucoma is untreated, it probably would decrease by 1.1 decibel per year. That is in the perimetry. So that means if a patient comes to you with a 10 decibel loss already, and he's losing almost to 1.1 decibel every year, he's probably going to be visually handicapped in the 10 years time. If he comes here 60 years, by 70 he will be handicapped. But a clinical glaucoma, where you treat him well, ideally the patient shouldn't be increasing by more than 0.4 to 0.6 decibels per year. So that's an important thing to watch when you are following up the glaucoma cases. And similarly, this is a trend analysis. If you look at this visual field index, here this is 100% is normal. So number of tests are required. You do a number of tests, then it gives you this gives the trend. And of course, you can see what is going to happen in the next 5 years from the trend analysis. So the patient is going to reach somewhere here in 5 years. And this is what it looks like, GP report, glaucoma progression analysis report. And if you have only three perimetries, you won't get the progression here, you won't get the trend line. Similarly, if you have more than, you should have at least 5 fields over 2 years period. So if the period is less than 2 years, even then you won't get that extrapolation here. And if you have multitude of tests conducted over more than 2 years time, then you have this trend line. And you can see now, this shows in 4 years the patient is going to go blind. So you have to take the call somewhere here. So this is one way you analyze visual field index. This is how you go about it. And if you look at this, then there are of course event analysis. You have these symbols. Small dot indicates a point not changing by significant amounts. Small open triangle identify deterioration in the 5% chances are that it's progression. Similarly, half-filled triangle and solid triangle. So these are the symbols representing. And if you look at the cataract and now rate of progression needs to be monitored. You see this case, 0.9 is the rate of progression, and this patient is doing very well, 0.9% per year. And similarly, this is another patient, the rate of progression is 2.2% per year, and you can see the progression is fast here. And they have another patient, progression is 5% per year. So this patient is going downhill. So you can see from this what is happening to the patient, how the patient is progressing. And the important thing is that if you want to convert this percentage into decibels, roughly 3% VFI is equal to 1 decibel loss. These are risk factors associated with progression. Of course, then you have OCT, where you can see the progression. You have progression analysis there in the OCT also, and there are maps which provide the RNFL thickness, how it progresses. Then of course now we have a ganglion cell analysis, which again sheds light on the cases. You can see this is a RGC showing a temporal raphe sign is there. There's a thinning in this area. And OCT angiography is the new kid on the block. We are delving into that. The fundus photo, this is a loss of capillaries, and this octa vessel density map is less here. The superficial capillary plexus, deep capillary plexus, and choriocapillaris. So there is an alteration in their density. And now the last is, we should know OCT versus perimetry in early glaucoma. If you see the OCT here, you can see that OCT there is a little change over 4 years time. You can see something has come up here. If you see the OCT slope here, there is a loss is minus 2.28 micron per year. That means you can pick up the changes in the early glaucoma. Whereas if you look at the fields, there is hardly any change in the visual field in early glaucoma. And the slope is like this. The loss is 0.25 decibel per year. So in early glaucoma, OCT is a better modality. And whereas if you look at the advanced glaucoma, and you can see that OCT is more or less same because of the floor effect. You can see slope of OCT is not changing at all. Whereas if you look at the fields in advanced glaucoma, still you can pick up what is happening there. So you can see there is a progression. So early glaucoma depend on OCT for progression, and in the late glaucoma, visual fields is the only thing to be done when the floor effect is there. To conclude, progression detection is paramount in management of glaucoma. Tests cannot replace clinical judgment. They are intended to be used in conjunction with the multiple clinical tools. Treatment modality needs to be changed to prevent further damage, and augment therapy is required. Thank you very much.
Thank you so much, sir, for a wonderful talk. Sir has very well highlighted the fact that glaucoma will progress and all, but we can just decrease or increase the time in which it will progress. And also the floor effect in advanced glaucoma, OCT doesn't help in advanced glaucoma. Sir, what is your take on GCC, role of GCC in advanced glaucoma? Is there any role of GCC in advanced glaucoma?
CCD?
GCC, ganglion cell count.
Ganglion cell, okay. GC is helpful in advanced glaucoma, and especially in the myopic disc, where the discs are, it's very difficult to get the good RNFL, but GCC analysis is helpful in those cases, and advanced glaucoma also.
And sir, do you recommend doing 24-C or 10-2 in early cases to document early progression?
Yeah, if you are doing the 24-2 test, the likelihood of missing the central field effects is pretty high. Like 10 to 20% cases may show 24-2 field normal, but if you have a suspicion that patient is having little small notch there, or some you find kid looks glaucomatous, or their pressures are high or diurnals are high, then you should go for 10-2. But now what they advise is go for 24-2 as well as 10-2 in these cases. But there is a now newer test which is 24-2C. So in this 24-2C, they have added 10 points in the central area. Because if you look at these 24-2 tests, there are only about 6 points in the central 8 degrees. So here you are testing more number of points. So in the central 10-degree field, in 24-2C test, we have additional 10 points in that area to find out the central field effects.
Thank you so much. Dr. Munish would like to add.
Thank you, sir. Thank you, sir.
So our next speaker is Dr. Gurvinder Kaur, HOD DMC. She will be speaking on From Shadows to Clarity, the power of visual field testing in glaucoma. Handing on to Dr. Gurvinder Kaur.
Good morning, everyone. So today I'm going to talk of the power of visual field testing in glaucoma. My previous speakers have touched upon glaucoma perimetry in a bit. So the perimetry, as we all know, is to measure the extent of visual fields. So there are various programs in perimetry. We'll stick on to the glaucoma fields only. So usually what we do is 30-2, there the number of points tested are 76. 24-2 is another test which is very helpful in glaucoma, and it reduces the test duration. It actually omits the temporal points in 30-2. 10-2 is usually used for macular screening in case of advanced glaucoma. Then you have a macular program in which in case of advanced glaucoma, if you want to see a macular split, then macular program is better. And as Sir said, there is one more new entity which is 24-2C, where the extra 10 macular points are added to 24-2 to look at the macular status. So now when there are so many programs, how do we decide which program you should be doing? So if you have a patient of glaucoma suspect, go for 30-2. If it is an established case of glaucoma and we need to see the progression, go for 24-2. If it is an advanced case of glaucoma, 10-2 is good. To see for macular splitting and to see the outcome of trabeculectomy or to see the washout phenomena, then you can go for a macular program, or in this case you can even go for a 24-2C. And very important to note here is for follow-up cases, please use the same program which you used in the previous test, because that is the only way by which the glaucoma progression analysis will be done. So this is the Humphrey-Fried analyzer report which is seen, and these has eight zones. So zone 1 is very important. It has the patient data to see, to correlate. You should know that the patient is the same, the age is there, the eye is the same, and the program is the same. Then we have zone 2, which has a reliability indices. On the left hand side you have the fixation losses. If fixation losses are more than 20% or false negative and positive are more than 33%, they are usually flagged and the test becomes slightly unreliable. So then we have the third zone, which is the raw data, and its pictorial representation is the grayscale, which is the zone 4. These are usually not looked at too frequently in a visual field charting. What is more important is zone 5 and 6, which has the total deviation plot and the pattern deviation plot. So the total deviation plot compares the patient's data with the normative age-related data, and it also has the p-values. So darker is the spot, more chances of the abnormality are there. Then you have zone 6, which is the pattern deviation plot. This is even more important in glaucoma. So the main function of this is to expose the localized defects that may be masked by either a generalized depression because of the media opacities or a elevation of the hill of the vision. So if in this case you see the total deviation plot is showing more defects, whereas the pattern deviation is showing less defects, which are more likely to be glaucomatous. The more defects on the total deviation may be because of the media opacities, corneal opacity or cataract. So next is a glaucoma hemifield test, very important point of Anderson criteria. So we need to know whether the glaucoma GHT is outside normal limits or there is borderline or within normal limits. Then this is very important, zone 8 is the global indices. So this has mean deviation, pattern standard deviation, and as sir said, the VFI, the visual field index. So as we all know, there is an arcuate arrangement of nerve fiber layer in the retina, and so are the defects. So when the glaucoma affects these arcuates, we have arcuate defects on the perimetry. So perimetry has many kinds of defects. The beginning is the nasal step, then you can have central or a central cecal scotoma, you can have arcuate or a double arcuate scotomas, and then complete loss of vision also. So the Anderson criteria, as we all know, takes three things into consideration if you're doing 30-2. Glaucoma hemifield test is outside normal limits. There are a cluster of 3 non-edge points, which should, with the p-value less than 5%, one of which should be less than 1%, and the pattern standard deviation p-value should be less than 5%, and this should be demonstrated on 2 consecutive tests. So looking at some reports, this is a normal report. When I show these reports, please look at the total deviation and the pattern deviation. So this is the nasal step. On grayscale also you can see the nasal step. So then you have the arcuate scotoma. So this is the inferior arcuate scotoma. Then you have the double arcuate scotoma in this case. Again an arcuate scotoma, another arcuate scotoma inferiorly. This is a double arcuate with a full inferior and a incomplete superior, and a double arcuate scotoma. So on a macular program, very important is to notice the split sign. This is the diagram showing the split sign. So if a split sign is there, there are high chances of washout phenomena after trabeculectomy. So glaucoma progression analysis has been beautifully told by Dr. Gurstinder. So but whatever sees black on perimetry is not glaucoma. There can be some artifacts also. Sometimes there is a trigger happy patient, so you'll see everything white, no defects. That's high false positive responses. Then you can have a clover leaf kind of pattern which is seen in high false negative responses when the patient doesn't want to, he keeps on pressing, he doesn't want to stop. Then they have a small pupil, so then small pupil can appear as a peripheral constriction of the fields. Learning curve. So from A to B, if you see the defects have reduced. So perimetry is slightly difficult. So we should give the patient a benefit of doubt and do at least 2 or 3 perimetries and come over this learning curve to actually analyze glaucoma. Rim defects, because of the lenses which we use, they can also cause peripheral defects. And last, the neurological defects. Everything again which is seen is not glaucomatous. The glaucoma does not respect the vertical meridian, whereas all the neurological defects will respect the vertical meridian. If you see defects on one side of the vertical meridian, so think of neurological defects. So this is showing a bitemporal hemianopia. Again, this has a homonymous hemianopia, left homonymous hemianopia. So, and at the end, I will conclude by saying that the clinical correlation is very important in diagnosing and seeing the progression of glaucoma. You should look at the disc findings and you should actually rely on your clinical acumen more than the tests. Tests are there to help, but clinically, if you see there is glaucoma or there is progression of glaucoma, take it like that. Thank you so much.
So I think Gurinder very nicely covered. So I have a couple of, questions for the benefit of audience. One is, which strategy you would like to use? CETA standard, CETA fast?
So
CETA
I
faster?
actually, because of
Yeah, I
less
understand,
time,
but I've just
so CETA fast or CETA full threshold we do not use nowadays because it takes about 20 or 30 minutes. So CETA standard or CETA fast, both will take about, CETA fast will take 5 minutes and standard will take 7 minutes. Any of them 24-2 should be used, not the full threshold. But when you take CETA fast and CETA standard, then the corrected pattern standard deviations are not going to come because they are not going to check short fluctuations. But that's okay, we can get the mean deviation and the pattern standard deviation.
So I think if the patient is coming for the first time, probably you would like to go for CETA standard or CETA fast?
CETA standard,
would be better.
standard.
And if he gets conversant with that test, then you can of course go to CETA fast. Other thing is that she talked about Anderson and Patella's criteria. So you take 3 non-edge points, but in 24-2,
Yes, yes.
there is no non-edge
Non-edge
point,
point,
remember
that,
this.
yeah,
Because
correct.
we have taken out all the
Correct,
edge
because that I
points in
told,
that.
that's only for 30-2. Because in 24-2, in any case, we have taken out the edge points. So we are just,
Other thing is that she's very rightly pointed out that never comment on a field sent by a colleague just for the interpretation. The reason is that patient may be having something on the fundus, he may have some lesion in the fundus or macular area, and other thing I want to stress is that, which I said already in my talk also, that whenever you have a little doubt, always go for 10-2 field in addition to 24-2. Because if you look at the inferior arcuate fibers, they come very close to the macula, which has been called macular vulnerability zone. So whenever there is an inferior notch is there, the chances of central field defects is very high. Because the upper arcuate fibers go around the macular area, but lower ones come very close to the macular area, and that is why I have seen that most of normal tendency patients, they develop inferior notch and they develop dense central scotomas. So anything else you want to say, Gaurav?
And one thing I would like to ask, ma'am, how frequently would you go for the visual fields in advanced cases?
advanced cases for visual field analysis, maybe you can go for 3 or 4 monthly
3
evaluation.
or 4 monthly you're going?
Yes. Because as sir pointed out, OCT is not going to show you much changes. So visual field effects have to be seen.
Yes, ma'am. And every time you're going for 10-2?
Yes.
Okay. Thank you, ma'am.
Nowadays the newer ones have the 24-2C also.
C,
That's
C
very
also.
helpful.
Thank you. Thank you, ma'am.
Thank you.
But
Ma'am-
24-2 is as yet being used more as a screening test, because there are no, database is not very strong with 24-2.
24-2.
This is more of a screening test as of now.
And ma'am, would you like to highlight how many fields for a routine glaucoma patient, like what should be the protocol of doing field testing in these cases? Because many of the practitioners may face challenges Because a lot of patients do not want to get filled again and again, but what is the standard protocol which we should follow?
What I personally do is, if the patient is properly controlled on drops and the IOP is within target, then I go for 6 monthly check. But if you see that the progression is very fast, then you can go for more frequent tests like three monthly or 4 monthly. Doing less than 6 months in a controlled is not required.
Very well pointed out. And one thing I wanted to highlight, that first 2 to 3 fields should be done in 30 days to 60 days, so that patient develops
The learning curve is gone.
And once the patient learns the test, then we can follow the same protocol. Thank you so
And
much.
I actually suggest everybody should do visual field analysis. Majority of us are above 40. एक तो हमारा screening हो जाएगा, and you'll actually know how difficult it is.
Thank you so much, Dr. Govinder, for a wonderful talk. Our next speaker is Dr. Munish Savan, HOD, Faridkot Medical College. He will be speaking on optic disc evaluation.
Good
Dr.
morning,
Munish Savan.
everyone. Thank you, AIS, for allowing me to speak on the topic of optic disc evaluation in glaucoma. As Dr. Gursatinder has very rightly told in these conclusion slides, that tests should not replace optic disc evaluation. Dr. Gurvinder Kaur has also explained very nicely that we should not rely much on the tests. So I will be speaking on how to evaluate the optic disc in a patient on glaucoma. As we all know, that glaucoma is a chronic progressive optic neuropathy associated with irreversible visual field defects, which may or may not be associated with raised intraocular pressure. So glaucoma is a type of optic neuropathy. Hence, the evaluation of the appearance of the optic disc becomes central to the diagnosis and management of glaucoma. Whenever we want to evaluate the optic disc, it should come in your mind that why we are evaluating the optic disc, how we should evaluate the optic disc, and what are the different signs which we have to look into while evaluating the optic disc. So there are basically 4 major goals for optic disc evaluation. First of all, we have to differentiate between a healthy and a sick optic disc. Thus, we can make the diagnosis of glaucomatous optic neuropathy. Next is that we can quantify the amount of damage, that whether the damage is mild, moderate, or advanced. We can monitor the change, and we can quantitate the rate of change by evaluating the optic disc. So there are different methods for evaluation of the optic disc. Out of all, slit lamp biomicroscopy is the ideal method, as it provides stereoscopic view of the optic disc and optic cup. And we can also measure the optic disc size also. With direct ophthalmoscopy, we can get good magnification. With indirect ophthalmoscopy, we can get an overall view, and optic disc photography can document the monitoring of the disease. So different things which have to be seen while evaluating the optic disc are the optic disc size and shape, the status of the neuroretinal rim, the status of the optic cup, whether there is any optic disc hemorrhage or not, whether there is any nerve fiber layer defect or not, and what is the status of the parapapillary region and retinal arteries. All these variables can be measured semi-quantitatively by ophthalmoscopy without applying sophisticated techniques. So we will be discussing all these variables one by one. So most important is the size and shape of the optic disc. So as we all know, optic disc is vertically oval and around 1500 microns in size. But there are large physiological optic discs, and a large physiological optic disc will have large cups. So every large cup is not a glaucomatous cup, and every small cup is not a non-glaucomatous cup. So we can measure the vertical disc diameter with the length of the vertical beam of the slit lamp light also. So next come the status of the optic cup. As we all know, optic cup is the central excavation in the optic nerve head. So we should stereoscopically evaluate the optic cup, because it has a relation with the normal optic size also. So around 0.2 to 0.3:1 is the normal area of the cup disc ratio. Whereas early and moderate glaucomatous damage in small disc can be missed because of the erroneously low cup to disc ratio, as we can see in this glaucomatous optic disc, which has a very small disc along with a small cup, but you can see in that ISNT rule is not being followed, and there is a glaucomatous damage to the optic disc. So next comes the vertical cup to disc ratio. In glaucomatous eyes, vertical cup to disc ratio is more than the horizontal cup to disc ratio, but in normal eyes it is reverse. Horizontal CD ratio is more than vertical CD ratio. So we should measure the vertical CD ratio in all optic discs. Normally there is no disc asymmetry, but in glaucomatous eyes there can be optic disc asymmetry between the two eyes. Next comes the status of the neuroretinal rim. In glaucoma, then there can be thinning of the NRR, failure of the NRR, there can be notching. All these things will not be there in a normal cup, which will be a pink looking NRR. A notch is a localized defect in the neuroretinal rim on the cup side of the rim, as we can see here. So usual sequence of NRR loss starts from the inferotemporal quadrant, goes into the supranasal quadrant. But in contrast, in non-glaucomatous optic nerve damage, the NRR is not always affected, and hence contour of the NRR is maintained. ISNT rule is there in a normal eye, which is being followed, in which inferior quadrant of NRR is more thicker than the superior, then nasal, then temporal. But this ISNT rule is not being followed in a glaucomatous eye, as we can see in this cup, in which inferior is less than superior, which is less than nasal, and more than temporal. Similarly, in this disc, inferior quadrant is very thin. So we should always look for the ISNT rule, whether it is being followed or not. In this picture also, ISNT rule is not being followed. So these discs are having signs of glaucomatous optic neuropathy, which can be easily diagnosed. So next comes the status of the optic disc hemorrhages. As sir has very rightly pointed out, that these are splinter or flame-shaped hemorrhages present at the margin of the disc. These are hallmark of the glaucomatous optic nerve damage, located generally in the inferotemporal or superotemporal margins. They are more common in NTG, suggest the progression of the disease. As you can see in these optic discs, there is a localized hemorrhage which is splinter shaped, present in the inferotemporal or the superotemporal quadrants. So next comes the status of the retinal nerve fiber layer. Retinal nerve fiber layer contains the retinal ganglion cell axons covered by astrocytes and bundled by processes of Muller cells. Retinal nerve fiber layer defects are seen as bright fine striations fanning from the optic disc to the periphery. They are more easily visible with dilated pupil and green light with a clear optical media. There can be localized defects or there can be diffuse loss of RNFL. Localized defect is there when there is early or moderate advanced disease, and diffuse loss of RNFL is there in advanced diseases, and underlying choroidal vessels can also be very easily seen with peripapillary bearing of the retinal vessels, as we can see in these optic discs which have localized RNFL defects, and this picture is showing diffuse loss of RNFL. So these are the optic discs showing localized RNFL loss starting from the optic disc going to the periphery. So this is diffuse RNFL loss in which underlying choriocapillaries are visible and peripapillary vessels are bared. So next comes the examination of the parapapillary region. So two zones are formed, central is the beta and the peripheral is the alpha. So beta zone occurs more often in the glaucomatous eyes than in the normal eyes. It helps to differentiate various subtypes of glaucoma. So peripapillary region becomes important in the evaluation of glaucomatous optic neuropathy, as Dr. Gursatinder has very rightly pointed out also. Next comes that whether this disc is glaucomatous or non-glaucomatous, because it is very easily being missed by, especially by the postgraduate students. So the basic difference between a glaucomatous and a non-glaucomatous optic disc is that in glaucomatous there will be more cupping, but in non-glaucomatous there will be more pallor. And when we do the visual field examination, the glaucomatous disc will have a vertical horizontal meridian following, and the neuroophthalmic cause will follow the vertical meridian. Next comes the status of the retinal arteries. There can be diffuse narrowing or focal attenuation of the retinal arteries, which is more common depending upon the amount of the disc damage. As we can see here, this is a focal notch on the retinal arteries. So this is diffuse damage of the retinal artery. So while examining the optic disc, there are some few optic disc photographs which show the early damage of the glaucoma, in which there can be optic disc hemorrhage. There can be one pole of the disc which is damaged. Two poles can be affected. In this cup will be advanced. In advanced disease, there is the more CD ratio. So we can calculate on the disc damage likelihood scale by evaluating on the by drawing the disc diagrams or by taking the serial fundus photographs. So this is one case which is a 52-year-old man present for routine checkup. We have seen the CD ratio 0.7. On visual field, there is superior arcuate scotoma. This is again a suspicious disc having central vision loss. This is again a suspicious disc, but the case is of neuroophthalm having vertical visual field which is following the vertical meridian. Thank you.
Wonderful talk, Dr. Munish. I think very well highlighted the importance of optic disc evaluation. We all as glaucoma specialists understand how much, I think the most important thing is very good clinical disc evaluation, because a lot of time we miss defects on perimetry and other things. But RNFL defects clinically if we see, then it is definitely a glaucoma. Dr. Gursatinder would like to add.
So I tell all my postgraduates that there are two skills you need to master for glaucoma. One is optic disc examination, other is of course the gonioscopy. And if you're working in a field where you don't have access to OCT or Humphreys or other technologies, which are of course required, but high degree of suspicion is always there whenever you find some notch in the disc or some RNFL defect is there. And I think that this is a very important skill to learn 90D examination and gonioscopy. Very nice talk, Dr. Manish. You covered it very comprehensively. Thank you.
Sir, I have a question. It's a very nice talk delivered. So just one thing. So do you think a cup of 0.7 should be considered as this suspect?
So this suspect 0.7 cup will come into the definition of glaucomatous suspect. But for making a diagnosis of glaucoma, as Dr. Talveer has told in the morning, that we should see all the aspects. We should look for the other signs of glaucomatous disc also. Then we can proceed for different investigations also. We can go for CCT, we can go for the diurnal variation. Only then comprehensively, on just seeing a 0.7 cup, we should not say that this is a glaucomatous cup.
Yes. Yes, sir. I think we should look at various other signs, the RNFL signs, the notching, the focal loss, and everything.
Everything has to be
RNFL
seen.
defects,
Yeah.
and then we can decide. Thank you, sir. Thank you.
I request AV team to please attach the laptop. AV team, please. Till the time they are attaching the laptop, sir, as we have time, a quick question. What is your take on SLT? Nowadays, SLT is being popularized a lot as laser treatment for glaucoma and the true laser treatment for glaucoma. So what is your take? Dr. Neetu, I think you have been doing SLT a lot.
Yes, definitely that do works. Basically, that works in the newly diagnosed patients, the naive patients who are not on any topical drops, and it is very good in if we have started it as a primary initial therapy. So that works. But yes, in some eyes, especially in Indian eyes, because of the hyperpigmentation of the iris, there is response, but that tends to fade off easily. That is there. So repeat SLT can be needed in few years.
And the important application is of course pregnancy.
Yes, sir. Yes.
So
yes.
where I think this is the best modality
best,
to
yes.
take care of glaucoma.
Yes.
And is it, can you supplement if patient is already on one or two drugs? How does it affect? Does it affect IOP?
Yes.
And to what extent?
So actually it works, but then again I said that it is better, the SLT works better in those eyes who are not on any treatment. So the response tends to fade off.
So primary treatment with SLT you are saying
Yes,
it's
sir.
as good as one drug they
Yes,
say.
sir.
Yeah.
Yes, basically
As good
as
maybe
one.
timolol.
Yeah.
Right?
So yes, yes.
And how long does the effect last?
So
Normally, like average
normally,
or?
so usually the light study showed that the effect lasted for at least 6 to 10 years, but in Indian population it do fades away in less than 5 to 6 years.
Yeah, the main thing is the point here to highlight is and take home is that SLT is the treatment to start, not the end, because many people are supplementing like to avoid surgery. If the IOP is not being controlled on maximum medication, we are supplementing them with SLT. I think that is not a good option. But to start the treatment, like patient, once we are offering them a PG or one drug, then in those cases SLT is I think a very good drug to avoid single medication.
Yes, yes, that's true. And now we have minimally invasive glaucoma surgeries that have now come up, so that can be given in, that can be started as in early to moderate glaucoma cases, along with the cataract surgery.
So on this note, I invite Dr. Gaurav to give his talk on minimally invasive glaucoma surgery. He's been a glaucoma fellow at PGI Chandigarh.
Thank you so much, Dr. Sundar, for a kind introduction. At the outset, I would like to thank POS and AIOC to give the opportunity to speak in front of you all. So the term MIGS was first seen in 2012 as an umbrella term which for devices or treatments which has main 5 features, that is ab interno microincision, that is conjunctiva sparing surgery, because previously all the surgeries involve the opening of conjunctiva. Then minimal disruption of anatomy, lowering of IOP at least 20%. It has rapid recovery and high safety profile. So why MIGS? Because from a traditional surgery, MIGS have significantly lower complication rate, faster recovery time, less post-operative care, and possibly earlier intervention, and quality of life impact is very much lower. So, but still, although it seems very promising, but there are a lot of limitation of this procedure. It is not an effective in advanced cases. Long-term safety data is still unproven. Cost is a major challenge in developing countries. Also, it has a bit of learning curve because we need to be skilled in gonioscopy and specifically intraoperative gonioscopy. And patient selection is critical. So main question is when to do MIGS. Are all patients fit for MIGS? No. So the patient in which glaucoma patients have requiring treatment, if IOP is uncontrolled despite maximum medication, then still the gold standard is trabeculectomy or any glaucoma drainage device. But if the IOP is controlled on topical medication or it is in early phase, then we should look for if the patient is having cataract or not. If there is no cataract, then we can do mild to moderate glaucoma standard on MIGS, which is trabecular meshwork based, or GATT. If cataract is present, then we can combine MIGS with cataract surgeries. So based upon the utility of or the mechanism of action, there are various kinds of MIGS, but majority of MIGS work on trabecular meshwork. One Zen implant came which worked in subconjunctival space. Suprachoroidal space, CyPass and iSense Supra are there, then ECP are there, but majority, I think MIGS work on trabecular meshwork. So indications are specifically mild to moderate open angle glaucomas in combination with cataract surgery and ocular hypertensive patients who do not want to put medication. So there are very basic requirements to start MIGS, that is equipment and skill. So in equipment, not much of things are required. You just need a direct gonioscope, which is the most commonly Swan-Jacob lens is used, and a good microscope with tiltable head, because we need to tilt the microscope at 45-degree angle to see the angle in these cases. Then learn the art of gonioscopy. First learn it in clinics and then intraoperatively. You can learn the art of gonioscopy in routine your cataract patient before starting MIGS, but you need to learn this because if you are not able to visualize the angle intraoperatively, you will not be able to do MIGS. So the popular MIGS, as there are a lot of implants, but non-implant based MIGS are popular in India, like BANG, KDB, and GATT. BANG is basically bent angle needle goniotomy. Nowadays, it is the most commonly done MIGS procedure in India. And I think all cataract surgeons who are doing cataract surgery in glaucoma patients should do cataract with BANG nowadays. So I'll be showing a video. So this is a video of goniotomy in a pediatric patient. It is very handy in those cases. This is Swan-Jacob lens. Here we can see with the help of needle, we are just slicing the trabecular meshwork. So it helps you identify the structure very well. So now coming to bent ab interno needle goniectomy in primary angle closure glaucoma. So first you need to bend the needle, your 24 gauge needle, towards the bevel at an angle of 40 to 90 degree. Then this is a case of angle closure glaucoma with 18 IOP on 2 medication and cataract surgery was required. So then use a direct gonio prism and visualize the angle structure very well. So once you visualize the angle structure, then you insert the needle, and then you can see here, you just slice the trabecular meshwork. You need to identify the trabecular meshwork first, then you just slice the trabecular meshwork and just strip off. There is minimal amount of bleeding. We can treat 100 to 120 degree angles and then do a routine cataract surgery like we do. So there are a lot of data published on BANG. This is a study by Dr. Tanush Dada, and they have demonstrated that at 12 months, 87.5% cases had actual surgical success, and they noted surgical success in more than 20% of IOP reduction. So another is GATT, that is gonioscopy assisted transluminal trabeculotomy. In this, we treat 360 degree of angle. It can be done with the help of illuminated microcatheter, that is eye-track, or just with the help of Prolene suture. And GATT is the angle surgery which controls the IOP maximum. It controls almost 45% of pressure in at 4 years, but this is the long-term study demonstrating the outcome of GATT, and they says that at 4 years almost 50% fails, but initially there was 45% reduction. So long-term success is still questionable in these cases. So the other popular MIGs are like iStent, Trabectome, Hydrus, Omni, Streamline. There are a lot of things coming up. So iStent is an implant which comes preloaded. It is inserted into the trabecular meshwork. It bypasses the TM and it directly drains the aqueous into the Schlemm's canal. It is loaded first and then directly inserted with the help of gonioscopy assisted. So this is a study which shows that it is comparative data in which cataract surgery alone was done and then cataract surgery with iStent was done, and they found superiority of IOP control with the help of iStent. This is a Hydrus implant. Hydrus implant is another implant which is 8 mm long device. It is implanted into the Schlemm's canal through the gonioscopy assisted thing. And in this, aqueous is outflow into the Schlemm's canal and into the distal outflow veins. So this is a study comparing the compare study which compares the data of Hydrus with iStent. They found that iStent has inferiority over Hydrus implant, but Hydrus implant is, I think, it's not available in India right now. Then iStent Supra is there, which drain the aqueous in the supraciliary space. Then Cyper stand came. It was very promising because it drains into the supraciliary space, but it was then withdrawn. Then the Zen implant came. It was very promising because it was draining into the subconjunctival space. There was no opening of conjunctiva. It was loaded from the angle into the subconjunctival space, and it has perfect lumen of 45 micron, but it also failed. I personally feel all this fails because subconjunctival space is not a potential space, and the body tries to heal everything, and once it heals, they tend to fail. So take-home message for today is that the MIGS is bridging the treatment gap between medical therapies and more invasive surgeries, and can be performed as a solo procedure combined with phaco. But in today's scenario, if we are doing a phaco in a glaucoma patient, we should all learn MIGS, specifically bang, so that we can do in those cases, because it causes 20% reduction additional IOP in those cases, and also prevent the IOP spike in glaucoma patient. It just requires gonioscopy scale and basic instrumentation, nothing much, and can be easily started by a cataract or glaucoma surgeon. But the most important thing is not a procedure for advanced glaucoma, and TRAB remains the gold standard in advanced glaucoma. So, thank you.
Gaurav, very nice presentation. I have just a couple of questions, In our Indian scenario, of course, bang remains the treatment of choice,
Yes.
What is your experience with the bang, or what does the literature say about bang? How much IOP lowering is there with this, and how long does the effect last?
Sir, I personally feel that whatever MIGS we do, majority have 20% reduction, and it is a good case. If we are doing I personally do not recommend if the patient is on wandering and doing an intraocular surgery, but if I am going ahead in an open angle glaucoma for a cataract surgery, because we know that in open angle glaucoma only 2 to 3 millimeter mercury is reduced, but with combining it, bang in those cases reduce significantly. That 20% reduction is there. If we can put them off with one medication at least after a cataract surgery, then it is a very good procedure in those cases. The study, there are a lot of data coming upon bang from AIMS, PJ, and other centers also, that the effect lasts at least more than a year, because it is almost 20% reduction. But I personally feel all the cases in which there is single drop, because glaucoma is a progressive disease, the disease itself progresses with time. We don't know if the procedure fails or the disease is progressing, but it lasts for almost 1 to 2 years, not very long. The long-term data has not till now come up for 5 to 6 years that how it performs in long-term, but at least it is effective in 1 year.
So there's a lot of, promotion of iStent and many other stents in India, And what is their cost? What is the status today in India? And which are being used actually in practice?
So iStent, I think a lot of people are implanting in PJ. They have implanted. It is not freely available right now in Gurgaon. Many centers are using. South, many people are implanting. It costs almost 1 to 1.5 lakh single implant, but one implant reduces only 20% reduction. And I feel personally, coming from India, and that if a 2 rupee needle does the same job, then why to spend 1 lakh rupees?
And it's not probably covered with insurance also.
Yes, sir, it's not. So insurance is not covering in India right now.
Yes, please, Sanjay Parul. Do we have a mic?
Yeah.
Okay.
So once they stop working, so like what is the next course of action? Do you take them out, clean them, put them again, or you put new ones, you remove them?
I think they can be left in situ because it is very small, it do not affect anything.
Because one particular doctor, he was saying that he's studying over it, whether the stent can be removed, cleaned, and then put back again, just to try to see, where the why it has failed. Whether it's the drainage part or it's the eye stent
part.
itself, which has.
I think very interesting point you have highlighted. I think it is very good to know if we can remove that thing and then assess what has happened. It is the eye stent or the TM part.
So what do you do?
So I don't have personal experience of removing.
No. So what do you do? Like once those two stents they stop working, so you go for another two.
No. For another surgery. Yeah.
We have a couple of more minutes. We can take questions from the audience if there are any questions.
Yes, sir, I would like to ask Dr. Gaurav one thing. It was a very nice talk. So, are you doing this band before cataract surgery or after cataract surgery?
I do it before starting.
Because most of the time, most of the surgeons are doing after cataract surgery, because once you remove the cataract, the angle opens up more. So, it is easy to remove the trabeculum eschwa.
Yeah,
So I
because
think,
I personally feel the cornea clarity is much better in before starting the surgery, and also we don't have to wait for the hyphema to wash out, because while we are doing the surgery, it completely wash out. So the chance of post-operative hyphema are less.
But yes, sometimes it bleeds a lot,
Yeah.
and the hyphema can be a problem for you doing Rexis and further cataract surgery, because it keeps on bleeding for few minutes. So doing it after the surgery, then you can put air or you can put Visquin, that stops the bleeding.
Yeah, I think it is a personal experience. Of
Because I am doing it after
surgery.
cataract surgery.
Yeah, I think it is same like we have been implanting Ozurdex a lot previously when I was in PJ. We used to implant it at the end of the surgery, before the surgery, but now we are implanting at the end of the surgery. I think many surgeons implant, it's personal preference, I think.
Okay. And do you think, have you done this bang in angle closure patients?
In angle closure patients, sometimes I have tried, because we have done goniotomy in pediatric cases. In those there is high iris, and we just try to remove the synecdoche and then does it. But I personally feel that it doesn't make a difference in those cases, because I have seen that there is 20% reduction that already happens due to removal of cataract in those cases. So it is very difficult to comment if the effect has actually come due to bang or the removal of lens.
Thank you, Dr. Gaurav. Any questions from the audience on any of the talks? We have 2-3 minutes. Talveer, I would just like to ask you, do you do diurnal variation routinely in your glaucoma suspects, or you believe split diurnals are as good as that?
Usual office timings usually start at 8, So if you want to do a actual diurnal, the 7 a.m. or 6 a.m. IOP is something which you would really want to look at, because most commonly in around 70% of people, the morning IOP is the peak IOP. So if you can call the patient at 8 a.m. to your office and you're doing a diurnal, if it is not available in government medical colleges, we can still have, because in the ward we have a slit lamp, we can ask the patient to come to the ward and get an IOP done, right? But in practice, it's usually not possible. So we can do a split diurnal, or actual diurnal phasing usually needs a early morning IOP. So that is something which has to be looked at.
So Gurvinder, so how many cases you do, like 10-2, in all cases you do, or you do in only if there is a central involvement is there?
Advanced cases we do in all the cases, and as you pointed out, if we have the inferior notch, then 10-2 is done routinely. And if the glaucoma is progressing, then also I do 24-2 along with 10-2. Our perimetry doesn't has the 24-2C with it.
So basically, if there is central 10-degree involvement is there, you find some points there, then you probably go for 10-2, not
10-2,
otherwise.
Not otherwise. Or if it is advancing, the
So
glaucoma is advancing fast.
I just want my take on this is that if you have a little iota of doubt about the disc being glaucoma disc, do go for 10-2.
Beginning
Especially
only
if it is a inferior notching is there or
inferior. So
inferior
otherwise,
thinning of RNFL is there.
in the start also we should be doing 10-2.
And I'm saying if 24-2 is normal and you don't have 24-2C, then go for 10-2 in addition to 24-2.
So the main thing is not central or peripheral. The main thing is resolution. The 10-2 has 2 degree of resolution and the 24-2C has 6 degree of resolution. So we can have skip lesion in between. So that is the main purpose of 10-2. It's not the central or peripheral thing. Thank you all for attending the session. We'll wind up the session. I request all the speakers to please join the dais and have a group photograph. Someone please take the do we have the photograph over here?